Good afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on responding to the COVID-19 pandemic in Victoria, Australia. My name is Jeff Kwong. I'm a scientist at PHO, and I have the pleasure of moderating today's session. I would like to start with a land acknowledgement. I am speaking today from the land of Toronto. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. For those of you who are joining us from elsewhere in Ontario, I invite you to reflect on and acknowledge the land on which you live and work. Before we begin, I would like to mention a few housekeeping items. The chat pod has been disabled to limit distractions during the presentation. Please use the Q&A pod if you have any questions during the session. We will try to address as many questions as possible. If at any point during the session you experience technical issues, please email capacitybuilding@oahpp.ca. I would like to state, as the moderator of this session, I have no conflicts of interest. So it is now my pleasure to introduce the speaker for today's presentation, Dr. Stacey Rowe. Dr. Rowe is an infectious disease epidemiologist, a postdoctoral associate fellow at the University of San Francisco, and an adjunct senior research fellow at Monash University in Australia. Dr. Rowe has more than 15 years of experience in overseeing population-wide infectious disease surveillance, epidemiology, and control programs in Victoria, Australia. She completed her PhD at Monash University, where she examined the use of linked data to support communicable disease surveillance and control. Between 2020 and 2023, Dr. Rowe formed part of the executive leadership team at the Victorian State Government Department of Health as Director of COVID-19 Data and Intelligence. So now I'd like to pass it on to Stacey.
Thanks very much, Jeff, for that warm introduction, and also to Public Health Ontario for the opportunity to present. I'd too like to start by acknowledging the traditional owners of the lands on which I'm presenting today, the Ohlone people who lived and cared for this part of the world that I now call home, which is San Francisco and the Bay Area. And I'd also like to take a moment to respectfully acknowledge the many and varied traditional owners of the lands from my home state in Victoria, Australia. The experiences and reflections that I'll be discussing today largely occurred on the traditional lands of the Wurundjeri people of the Kulin Nation, and I pay my respects to elders past, present, and emerging from both regions across the globe. Also to note, I have no conflicts to declare, and the material presented here today does not represent the views of my current nor former employer, nor that of Public Health Ontario. So much of the content I'm presenting today is publicly available, but what I wanted to assemble here is tell a kind of story about Victoria's unique, as well as not so unique experiences in responding to the pandemic, particularly in the first 18 months of the response and prior to widespread availability and use of vaccines. And the story is not just an account of good or bad decisions, but one that can hopefully support meaningful reflections on some of the issues that we face as a public health community when managing public health crises. Many of the reflections in the latter part of the presentation are drawn from my role working in state government, but I'd also like to acknowledge several colleagues, in particular my co-leads in intelligence, Dr. Charles Elprin, Lucinda Franklin, Kira Lieb, and Andres Hernandez, and many others that formed part of the broader pandemic response team. So first, just a bit of context setting. Victoria is the southernmost mainland state in Australia with a population of about 6.6 million people, and it's highly urbanised. So nearly 5 million people reside in the capital of Melbourne and its greater metropolitan area. And Australia and Victoria are very culturally and linguistically diverse. At last census, more than 50% of the Australian residents were born or their parents were born overseas. And we're also seeing a generational shift towards younger age groups. So the number of millennials are now approaching the number of baby boomers. In Victoria, we have a very healthy economy, so it's larger than New Zealand and Singapore, and we have a range of key industries, but of particular relevance to the pandemic was our thriving international education sector, as well as our tourism, events, and visitor economies. Also, by way of context, I did just want to talk to our legislative landscape. Like Canada, Australia operates in a federated system of government, and key public health functions are devolved to the individual states and territories, and each with their own public health and wellbeing legislation. Emergency powers are also provided for by the states and territories. And it was this legislative landscape that was the key enabler underpinning some of Victoria's most stringent public health and social measures that were put in place in response to the pandemic. And indeed, the highly restrictive measures, which we'll talk to in a moment, led to quite spirited debate in Australia about the balance of public safety, human rights, and the distribution of power. And as a spoiler, ultimately, the federal government has since asserted its constitutional authority, and it now takes on more responsibility in coordinating emergencies that are national in scope. So here's beautiful Melbourne, a fantastic place to visit if you're so inclined. And our COVID story starts here. So this schema traces the first couple of months of the pandemic. I've put cumulative case counts on the left of the purple line. So the first case in Australia was identified in Victoria in a returned traveller from Wuhan, China. And at that point, coronavirus was listed as a listed human disease under the Australia's Biosecurity Act, and that enabled border security measures to be put in place. And so the first was banned entry from selected countries, but that list of countries expanded over time. And by the 19th of March, Australia had banned entry for all non-citizens. In the ensuing months, all cases were identified in returned international travellers, but on the 13th of March, Victoria first identified a case of community acquisition. So what was happening is that multiple international travellers were returning home to Victoria and inadvertently seeding local outbreaks. And while self-isolation was required of those travellers, at this point, more formal quarantine arrangements were yet to be established. As you would expect, Victoria undertook comprehensive case and contact management practices. We expanded contact tracing efforts over time to include a 2-week upstream contact tracing as well as downstream contact tracing to identify sources of transmission and to minimise that onward transmission. And this work was largely carried out by central public health teams. So until very recently, public health in Victoria was a centralised system with no or limited capacity at the local level. Only a few days later, on the 16th of March, a state of emergency was declared under the Public Health and Wellbeing Act. And that conferred extraordinary powers onto the Chief Health Officer, who was able to issue directions in order to reduce the risk to public health. And as you would expect, initial directions included things like banning non-essential gatherings and the shutdown of non-essential services, as well as stay-at-home orders that limited people's movement. So very similar to the rest of the world. But by the end of March, exponential growth was evident and the scheduled school holidays were brought forward, and that signalled the beginning of quite significant disruptions to early childhood and education sectors in Victoria. And on the 29th of March, following directives from the federal government, Victoria implemented a hotel quarantine program, which I'll talk to in a moment. So from the outset, Victoria swiftly adopted an aggressive suppression strategy. So the goal was to reverse epidemic growth, reduce case numbers through a series of restrictions and non-pharmaceutical interventions. And with Victoria in particular, adopting what they call the go hard, go fast philosophy to epidemic control. So the box on the right lists some of the key public health and social measures implemented in Victoria. And indeed, through much of the first 18 months of Victoria's pandemic response, those stay-at-home orders were in place with only 4 reasons to leave home. So getting food, exercising for a maximum of 2 hours, giving or receiving care, and attending authorised work. But as the epidemic scaled, additional restrictions were added, including a limit to only 1 hour of outdoor exercise, curfews in Melbourne, and of course, school and childcare closures. Over time, also place-based restrictions were introduced. So travel between the greater metropolitan Melbourne area and regional Victoria was also limited, trying to contain the outbreak to the metropolitan areas. So they arbitrarily constructed what we called a ring of steel, which was reinforced at checkpoints by the Australian Defence Force. So travellers between metropolitan and rural Victoria were restricted. So these local restrictions were on top of national biosecurity measures. And in theory, if the quarantine programs were highly effective at containing transmission, Australia was in an enviable position to be able to easily isolate from the rest of the world. And so that indeed was the national strategy, to hold cases back until widespread availability and use of vaccines. So onto the epidemic curve. So this somewhat busy but quite spectacular epidemic curve depicts the first 16 months of Victoria's COVID experience. So just to orient you, the top plot, we've got the number of cases overlaid with key events. In the middle plot, our estimates of R effective, and in the bottom shows our key mitigation measures with darker shading indicating more stringent restrictions. And as you can see, the restrictions in the beginning were introduced relatively early. And those stage 3 restrictions that were announced in early April also included closure of Victoria's much beloved pubs and bars and entertainment venues, as well as places of worship. And those restrictions early on did appear to flatten the curve, as they say, and only 2 months after they were introduced, some easing of restrictions were put in place. Before I go on, I did want to share with you the sentiment among the Victorian community at this time. So most notably, at the beginning of the pandemic, Victoria's population was highly compliant. Daily press conferences were headed up by Victoria's Chief Health Officer and the Premier, and they were highly effective at keeping the public informed and countering misinformation. In fact, a recent review of the communication strategies implemented in Victoria has shown that these trusted voices gave credibility to the public health messages being delivered. Bizarrely, much of Victoria's population viewed the Chief Health Officer as a kind of pandemic superhero. He gained cult status, and an unusual array of homewares and other paraphernalia started popping up for purchase. And even the Premier enjoyed support from the Victorian population. The daily press conferences were candid and frank and very detailed. In this clip, he's using his very unique Australian communications style, and he's telling the public that the pubs will be closed, and that doesn't mean that you can have your mates around at home to get on the beers. And that catchphrase turned into a bit of a meme through 2020 and beyond. But these daily snippets gave Victorians some degree of comic relief and respite from increasingly stringent public health restrictions that were being implemented. Of course, the early success was short-lived, and Victoria's main epidemic wave in 2020 is shown here, and it was found to be driven by outbreaks within the hotels being used for quarantining returned travellers, with leakage out to the general community. A state of disaster was declared in August, and that gave Victoria Police greater powers to enforce public health directions. And new restrictions were also introduced, including that overnight curfew in Melbourne. So this large community transmission observed during the second epidemic wave was able to be tracked back to the leakages from Victoria's hotel quarantine program. And the genomic surveillance and epidemiology gave Victoria those insights. So the breach involved a hotel quarantine worker who was infected by a returned international traveller who was detained in one of the many hotels used as part of the hotel quarantine program. And that single breach unfortunately led to a very large transmission network involving over 10,000 cases across 187 days. And then a further 2 breaches in a separate hotel was also identified and led to clusters of community-acquired cases. So genomic surveillance undertaken by one of Victoria's key reference laboratories, which is the Microbiological Diagnostic Unit at the Doherty Institute, was pivotal in providing evidence-based public health responses. And in this case, that led to the temporary suspension of the hotel quarantine program. And this evidence was also heavily relied upon in subsequent inquiries into the program. So this hotel quarantine inquiry was the first of many that would be conducted into the government's handling of the pandemic. It describes the velocity at which the program was established, and at its peak accommodating 4,000 people across 10 to 16 private hotels in Melbourne, with contracted private security guards as the primary mode of enforcement. So the inquiry identified several deficiencies in the program, which are listed in the right, but it included things like a lack of infection control levers being used within the hotels. They weren't fit for purpose for this purpose, and a lack of training for hotel quarantine workforce. Incidentally, the federal government has since built purpose-built quarantine facilities, including a facility in Victoria. So this phase of the epidemic was also typified by a change in demographics. It disproportionately impacted areas with increasing socioeconomic disadvantage and increasing cultural and linguistic diversity. And indeed, the cases reflected the socio-demographic of Melbourne's essential workforce. So these were the people who were able to move freely between their home and their place of work because they were conducting, essential authorised work. And as a result, we saw explosive outbreaks in settings involved, for example, food manufacture and distribution, health and aged care. And this changing epidemiology is also apparent in the figure on the right. So in the first epidemic wave, which is shown on the top left panel, it largely comprised cases among Victoria's most socioeconomically advantaged. So that's depicted in yellow. And that reflects the relative advantage of returning international travellers. But by the second epidemic wave, which is the bottom left panel, we see a shift with proportionally more cases among those experiencing socioeconomic disadvantage, which is represented in blue and the darkest shades of green. And the geographical distribution also changed. So as a result, place-based restrictions were increasingly being used. So with testing blitzes and the like, targeted to particular geographical hotspots in Melbourne. But again, these restrictions disproportionately impacted areas experiencing socioeconomic disadvantage. This image refers to a decision that the government made in June to lock down with immediate effect 9 public housing towers, or our social housing, in which a cluster of COVID-19 cases was emerging. And this sparked considerable confusion and anger and controversy across the population. And it again brought forward the extensive debate about the balance between disease control, public safety, and human rights. So this order was ultimately lifted within 5 days of the announcement being made, and several inquiries have since been undertaken into that decision. And some of the findings have noted, so this is the Victorian Ombudsman on the right, has noted that while temporary detention of residents may have been an appropriate a measure to contain the outbreak, the imposition of such restriction was done so without adequate preparations, and it did not appear to be justified nor reasonable under the circumstances, nor was it compatible with human rights. So in addition to the challenges that Victoria experienced with the management of hotel quarantine, this element of Victoria's pandemic response was also a negative one, but I think one that serves as a cautionary tale for the public health community at large. We know that people experiencing socioeconomic disadvantage commonly do bear the brunt of public health crises, and that's not unique to Victoria, nor is it unique to COVID. We know that a lot of that burden is commonly related to the social determinants of health, including poverty and overcrowding, limited access to services. So key to managing public health crises in these populations or in these settings is the need to really address the underlying structural factors that influence infection risk, such as crowded environments, and influence those social determinants of health. And indeed, I have a quote here from Dr. Muge Chivik, who is world-renowned epidemiologist, but she says we need to think about the systemic factors that influence viral propagation and not simply the characteristics of the individuals or the places that they go. And I think that was a really poignant message, particularly in light of the experiences that we had in Victoria. And I think going forward, that approach would support epidemic control holistically without inadvertently introducing inequalities. Reflections on this matter also resonate around the globe. Many have stressed the need for authentic engagement between governments and at-risk groups, and that these relationships need to be established before you need them. So I think on reflection, governments and public health leaders globally, I think would benefit from engaging with cultural, faith and community leaders during our so-called peace times, and that would build a foundation for more equitable public health responses in the future. So ultimately, through a strategy of aggressive suppression, Victoria did manage to curtail their major epidemic wave in 2020. Local elimination was achieved on the 27th of November. Our vaccination program commenced in February, and while there were some sporadic cases during that time, they were well contained. And local elimination was re-achieved on the 26th of March. So retrospective analyses have demonstrated that the control measures were successful in reducing R effective, and revised modelling estimates suggest that had there been no restrictions in place during that time over the peak in June, Victoria would have experienced an additional 18,500 infections per day. Victoria, and indeed Australia, was one of the few areas or countries globally that saw a reduced risk of all-cause mortality in 2020. So this is some of our work on the left, which shows a reduction in the observed all-cause mortality rate compared to historical means. And the figure on the right shows Australia's excess mortality rate relative to other countries in the pre-Omicron period. So Australia was second lowest only to New Zealand. And you can see the mortality rate in the US was 46 times higher than Australia's, and South Africa 61 times higher. Ultimately, ongoing cases and a very slow, moderately slow vaccination rollout through 2021 led to the reintroduction of restrictions. So Melbourne ended up experiencing 6 separate lockdowns, totaling 262 days, which gave it that name of the most lockdown city in the world. And despite initial compliance, COVID fatigue did set in. Melbourne wasn't immune to the demonstrations against government's handling of the pandemic. As shown on the right, we've got news coverage here from the so-called freedom fighters. Nonetheless, as promised, Victoria did lift restrictions in October 2021 to align with vaccination coverage targets of having 70% of the adult population vaccinated with a 2-dose regime, which we did manage to achieve. And while Victoria's story certainly doesn't end there, I did want to spend some time discussing the role of surveillance and epidemiology as part of our pandemic response. So again, just wanted to acknowledge a few key staff in the response working in the intelligence team. I've already spoken to a few key surveillance mechanisms, such as the genomic surveillance, but now I just wanted to share some reflections on building an intelligence workforce, maintaining and strengthening data sources and systems, and generating actionable intelligence. So just as contact tracing teams needed to expand, so too did intelligence teams. Victoria's public health program was centralised, as I'd mentioned earlier, but we had very limited epidemiology capacity, even by Australian standards. So over the course of the pandemic response, our team expanded rapidly from around 20 staff to 250 staff. On the right are some of the functions that we designed and recruited to, and we transitioned from an epicentric team to a multidisciplinary team able to deliver on the breadth of intelligence functions required. But we faced challenges along the way. We had a paucity of available workforce, both internal and external to government, and those gaps led to unsustainable workloads and ultimately burnout for many. We also initially had an over-reliance on single specialties. We thought we needed more versions of ourselves, but in reality, we needed a mix of specialties. And also our operating model was highly reactionary in the beginning. So the bread and butter work of an epidemiologist took full flight. We were able to quite spectacularly report on the current situation. So lots of descriptive epidemiology, very detailed outbreak network analyses. And this team was adept at feeding this insatiable appetite for data that our politicians and the media had. But a lot of investment went into responding to relatively inconsequential requests for data. And that operating model was difficult to shift over time. The other dot point I've noted here is our underdeveloped reporting systems. Now, that wasn't necessarily a workforce problem, but it did contribute to the additional pressures being put on our workforce. So staff were occupied just reporting rather than being able to delve deeper into the policy relevant questions that needed addressing. So I guess a couple of key reflections. First, enlist help and diversify. Building capacity through our existing or new networks, such as academic and other research partners would be valuable, and ideally building those productive partnerships ahead of time before the next major public health crisis. There's no reason why we couldn't set out proposed functions and a proposed operating model between governments and these partners ahead of time. By and large, we know the types of public health crises that might face us in the future, and we also know the critical intelligence functions that need to be fulfilled. So planning for these and building out an expanded intelligence model, I think, is crucial. And we also need to diversify our intelligence workforce. So as much as it pains me to say, epidemiologists are not always the answer. We need data scientists and data engineers and the like, so that they can support the development of robust data systems and reports. And they can also help us with our data transparency and availability. And we need to harness those and other skills. And the second reflection is what I would call boring but important, and that's that organisational function and structures matter. I think we really need to be intentional when we're building our intelligence workforce and make sure it reflects those critical functions that we need. Our key learning was that we needed to ring fence a dedicated workforce to deliver on all of those functions. So yes, we needed to have a good team that managed situational awareness and time-sensitive reactionary reporting, but we needed to bolster advanced epidemiological and analyses team for those to focus on those slower burn policy relevant issues. And then also a team that could build and diversify, develop and implement enhanced surveillance systems. And I'll talk to that now. So we wanted to focus on modernising our data systems. And again, this could be considered a little boring to epidemiologists who like all the applied epidemiology work and the outbreak epidemiology. But I think strengthening our data sources and our surveillance systems is an important precursor to strengthening our intelligence generation. So I wanted to talk to three elements of Victoria's experience. So modernising our data systems and infrastructure, bolstering that passive surveillance system with enhanced surveillance systems, and enabling data access and integration. So first up, Victoria needed to modernise their core passive surveillance system right in the middle of the pandemic. So the existing surveillance system we had in place was adequately captured notification data, so the clinical and the laboratory and the epidemiological data, that was fine, but it wasn't able to scale. It didn't cope well with the testing volume, and it was also unable to support real-time data capture during public health interviews, nor was it able to support sort of the toing and froing between public health teams and the cases and the contacts. So all those workflows was unsupported. And as a result, Victoria's contact tracing teams continued to use paper-based questionnaires and then transcribe them into the state surveillance system. So it was a process that limited the ability for the state to scale the response. And also underlying that core surveillance system, there were limits to our reporting infrastructure. So in response, several enhancements were stood up to fill those gaps, but most notably during the pandemic, Victoria transitioned to an entirely new surveillance and contact tracing system. So this was a CRM, a Salesforce platform that automated most of the contact tracing steps, which was very valuable. And then for reporting, a key early focus was the design of an appropriate reporting infrastructure and the utilisation of business analytic tools. We also needed to augment our passive notification data with enhanced surveillance and secondary sources. So at the outset, we established a multifaceted surveillance plan. Not all elements of the plan were able to be implemented, but several enhancements, such as those listed here, were critical in providing intelligence to Victoria's public health response. Now, we've spoken to genomic surveillance, but I did just want to talk to a few others listed here. So disease severity, wastewater surveillance, and our use of linked data. So we had a morbidity and mortality monitoring program that was established very quickly. We only had a handful of cases, but in anticipation of the outbreak scaling, we implemented this. We were concerned that we were going to lose visibility on COVID-related severity of disease indicators. So this patient monitoring program capitalised on an existing healthcare-associated infection surveillance system, VICNIS, which is a government program. And Data from all COVID positive cases that had been hospitalised were transmitted every day between all hospitals in Victoria and the Department of Health. And they transmitted key severity of disease indicators. So whether or not the patient was on the ward, whether they moved into ICU, whether they had a requirement for ventilation, and then looking at key outcomes such as length of stay and death. We also use this surveillance system to examine hospital-acquired infections. And this system ensured that Victoria did not lose visibility of COVID's impact on the Victorian population, and it enabled accurate reporting and monitoring of disease severity. So here is a tweet that the Victorian government sent out every day, and it contained those stats on severity of disease, and also we were able to monitor trends over time. Another successful program was our wastewater surveillance program. This was a collaboration with Water Research Australia. It was a new program that evolved over time from a proof of concept pilot to an embedded program that did inform targeted control measures. And the program enabled monitoring of quantitative levels of SARS-CoV-2 fragments in our wastewater system, as well as new and emerging variants. And the data from the program was commonly used to support targeted testing campaigns and health promotion messaging. We conducted an evaluation of the program. While it was only moderately sensitive, it was in fact highly specific, meaning that catchments with a positive wastewater detection likely did contain infected residents. Now, this was less useful in Melbourne, where we had widespread number of cases and really high incidence, but it was very useful in low or no incidence rural settings and in areas where incursions were unexpected. And the final surveillance enhancement that I did want to mention today was Victoria's enduring linkage, data linkage program. So this was a pre-existing program that saw the linkage of disease notifications with key disparate data sets, such as those capturing hospitalizations and deaths. And that was turbocharged during the pandemic, and the linkage program was actually being undertaken every day. So key outcome and other disparate data were being linked into our notification data. Software was also configurable to accept new data sets, including federally held data sets containing things like immunizations and pharmaceuticals. And there were several applications to the linked data program listed here, including, for example, better understanding risk factors for disease, severe disease, estimating vaccine effectiveness, and exploring the broader impact of SARS-CoV-2 infection on non-respiratory complications among the population. So from a systems point of view, I guess my key reflections are here. Complex public health problems often require a network of disparate data. And I think public health intelligence teams across the globe should ideally identify and, where possible, pre-establish some of these data sources and enhancements before the next crisis. And we know commonly which data points may be missing in traditional disease notification systems, and these might be severity of disease indicators, but it might also relate to data among vulnerable populations, or it might relate to data among key settings that commonly bear the brunt of infectious disease epidemics, such as aged care, prison, early childhood and education settings, for example. So I think pre-establishing surveillance systems or thinking about how you're going to ensure visibility in these areas during a public health crisis would make sense. And data capture protocols and software, and indeed the partners who might be able to help deliver these programs, can be identified ahead of time, and quite plausibly could be disease agnostic as well. Additionally, I think we need to think about systems that can better estimate prevalence. I haven't mentioned this, but a serosurveillance study was conducted in Victoria, but it was relatively late in the piece. And unlike the UK, we didn't implement a random population-based sampling program, which would have given us additional insight into true community incidence over time. And secondly, data linkage is key. I would urge governments to unlock the value of the data that they have stored in other government departments, for example, and establish an enduring linkage, a data linkage program between your key public health data sets and other health and non-health related data sets. So working with Justice and other health departments would be valuable. I think a lot of the data that we need to generate intelligence is already available, and we've got the technological capabilities policies to support linkage. In Victoria, some of the legislative and administrative barriers were there, but were able to overcome those challenges. So I've covered workforce and systems, and now I wanted to move on to the real crux of it, which is generating actionable intelligence. Now, some of the early challenges experienced by Victoria are listed here on the left. And I've already mentioned the reactionary operating model that we had in place, but there were several other challenges, including what I call death by dashboard. So as our reporting infrastructure matured, we ended up with a swathe of dashboards and a multitude of reporting products. Those were disseminated to multiple stakeholders. But the problem was that the products contained a lot of numbers, but less intelligence, and what we wanted was the other way around. So solutions to these problems, including ring fencing a dedicated team to work on more advanced epidemiological analyses, establishing consolidated reports, and we also established an oversight committee with the Chief Health Officer to support prioritisation of those policy relevant questions needing addressing. So just quickly, here's a grab from Victoria's Consolidated Surveillance Report. This is still being published to this day, once a week on the web. And over the course of the pandemic, our team did generate a multitude of actionable intelligence to inform the response. However, very few of our technical reports were released publicly. So that limited Victoria's contribution to the global scientific knowledge base. And I think the experience of other countries was notably different. So technical briefings and reports arising from the UK's Health Security Agency, for example, I would consider gold standard. They also established a multi-centre clinical trial in the UK, the recovery trial, which was saw the sharing of government assets with the research community. And there are also, as you're all aware, a multitude of peer-reviewed publications arising, in particular from Israel. They provided us with the real-world evidence of the safety and effectiveness of vaccines. So quite possibly the reason Victoria lagged other parts of the world in participating in research collaborations and publishing our findings might have been due to a perceived dichotomy between operational intelligence and research. I'd argue that that dichotomy is false, and that really all public health research needs to be sort of policy or operationally relevant. And making data publicly available, I think, would serve as a mechanism to both engender trust in governments and to help broaden the scientific knowledge base. And indeed, a review of the COVID communications in Victoria did recommend that the government invest in data and analytics and make it publicly available. And I think that recommendation has relevance across the globe. So how do we achieve this? Investment in public health surveillance and research infrastructure, I think, is essential. It really helps governments delve deeper into those complex policy relevant questions or research questions, whatever you want to call them. And of course, investment in data linkage. And I think investment in those two areas will pay dividends in the form of actionable intelligence going forward. And lastly, our findings need not be limited to local application. I think we should share those findings to support the broader public health community. And it's not necessarily a nice thing to do. I think it's a necessity. I think governments have a responsibility to do so for their citizens. So we're coming to the end of the road, despite the early success COVID ensues in Victoria as it does across the world. And coinciding with the lifting of restrictions in October was the onset of the Delta and Omicron epidemic waves. COVID is now the third leading cause of death in Australia, unfortunately. And like elsewhere, we do struggle with the significant and unknown impacts of long COVID. However, Victoria had to lift restrictions at some stage. I think, well, the real world effectiveness of vaccines was largely unknown at that time. So some could argue that putting in those highly restrictive measures was a gamble worth taking. The synopsis on the left of this slide here shows is a quote from one of Victoria's most prominent public health research institutions, the Burnet Institute. And they say that on balance, Australia's COVID mitigation strategy was remarkably successful, but it resulted in inequitable health, economic and social burden. And the figure here again shows the various countries' excess death rate relative to Australia. So now in the Omicron period or post-Omicron period, Australia's mortality rate is comparable to countries like Sweden, Singapore, Canada. And in the case of Sweden, this was achieved in the absence of lockdowns. So I guess in Australia, around the world, we continue to grapple with questions about the best approach for future public health threats. We know that there will always be a trade-off, but we think about now, is there a middle ground that might be less punitive? Do societies respond better to more carrots and less sticks? We know other reflections on past public health crises have pointed to the fact that by and large, people generally do the right thing when faced with adversity. So we think now more, well, what is the role of collective action or personal responsibility? But I think governments need to think about how they can provide the necessary environments for that action or that personal responsibility to shine. So I certainly don't profess to know the answers to these questions, Jeff, but I think I might instead leave you with this summary slide of some of my key lessons learnt and a few reflections on potential pathways forward for COVID-19 control, and thereby saying thank you very much for your time.
Okay, thanks so much, Stacey. So now we're going to move on to the Q&A segment of this event to address some of the questions from the audience. So please continue to enter your questions into the Q&A pod if you haven't already done so. All right, so first question is, how did you scale up the staffing levels? Where did the skilled staff come from? And what happened to the staff after the response?
Yeah, thanks. So in the beginning, we really called upon our informal networks with universities and other what we would call surveillance partners or sort of other agencies that were funded by the government to deliver other surveillance functions. So over time, so we ended up drawing very heavily on undergrad, sort of Bachelor of Science graduates, Master of Public Health recent graduates or students that were currently training, and brought them into the department. We also relied very heavily on some of the staff working in the acute health sector who weren't part of the acute response, but were able to be drawn in to support broader public health functions. In answer to the response of where are they now, so we scaled up in such a enormous way that couldn't be sustained over longer than 2 or 3 years, and so over time the scale of the response did pack down, and so I assume that additional workforce has now been embedded back out into their home institution, or in the case of Victoria's public health response now, what we did is it was a centralised response. So just in the state government was the headquarters of the Department of Health. But essentially what we did over time was devolve public health functions to local areas. So what happens is that through partnerships with the acute health sector, we've now created regional or local public health units. And so a lot of the staff that were brought into the response centrally then ended up picking up positions out in the local public health units.
Interesting. Next question. Did you have any independent modeling groups that produced modeling and or other analyses of the situation that did not agree with your assessment? And if yes, how did you handle that?
Ooh. So yes, we did have independent mathematical modelling teams that worked with us to develop the modelling expertise. So we didn't have any a mathematical modelling team within the health department at the outset. So we engaged with our surveillance partners and research partners to provide that for us. So it wasn't really a matter of whether we did or didn't agree with them. They were a funded provider for us. And then at the same time, there was a research institution that was funded to provide mathematical modelling for the whole of Australia. So there was a few local groups, as well as a group that supported Australia-wide mathematical modelling. From an executive sort of leadership point of view, you know, I know the Chief Health Officer and us all as a team took into account a range of evidence, both the mathematical modelling, which is imprecise, and you know, there's that quote that people say is all modelling is wrong, but it does give you an indicator of what could happen. And so those insights were taken into account, along with the empirical evidence emerging from the outbreaks as it evolved. So I don't know whether it was ever a consideration of that what did we do if we didn't agree. I think it was one of the many pieces of information that our leaders needed to take into account as to what was happening, and make an informed decision based on all the available evidence.
Mm-hmm. There's a lot of great questions, so I'm having a hard time picking. I'm just trying to get through as many as we can during the remaining time. You know, how involved was the political arm of the government in influencing public health measures that were implemented in the state of Victoria?
Yeah, that's a really good question. So in the beginning, and my presentation really did reflect that beginning sort of 12 to 18 months of the pandemic. In the beginning, I think our politicians were very responsive to our public health experts, and the public health orders and the directions and the advice being shared with politicians and the community at large were well heeded and followed, and it was a very supportive environment in the beginning. I think over time, and I know that other countries have experienced this as well, over time it did become more and more politicized. So as the outbreak scaled and the longevity of the public health restrictions were in place, that openness to rely on public health advice waned a little bit as well. So ultimately what happened, so Australia was, like I said, a federated system of government. Our federal government at the time was led by a more conservative political party, and then Victoria was led by the opposing and more liberal political party. So over time, that conflict, that political conflict, came to the fore. And ultimately what happened is that the federal government has since sort of asserted that constitutional authority, and now, rather than the Chief Health Officer and the states and territories signing off on public health orders, that is now devolved back to the ministers. So the politicians in the local states and territories are now responsible for signing off on public health orders on advice from the Chief Health Officer. So it did flip during the pandemic, but I think that flip really only happened a good sort of 18 months into the pandemic response. So it was alive and well in Victoria and in Australia more generally. And I think it was just a reflective of, I guess, the COVID fatigue that set in, and the restrictions that were being put in place, particularly in Victoria, that were quite punitive and quite restrictive, that interest waned and that compliance waned, and that's when sort of the political machinations really took off.
Mm-hmm. Mm-hmm. Are you able to speak to any COVID-19 science advisory committees in place to guide evidence-informed decision-making, and any lessons learned for the future in having structures to provide independent scientific advice for public health emergencies?
Yeah, I think in hindsight, I mean, there were sort of advisory science advisory committees in place in Victoria, but I think that they evolved over time, and they also evolved by different specialties. So, for example, in the acute health sector and responding to the impacts of COVID in the acute health sector, there was a large number of sort of advisory committees that popped up to help guide the government's response, as well as that interaction out into the community, as well as primary care. I know that there are other countries around the world that were able to establish at the outset a good scientific advisory body, multidisciplinary, that was able to more closely advise the government. I think in hindsight, establishing a scientific advisory body to advise the government would have strengthened Victoria's response. I think informally there were lots of engagement with other research institutions and scientists from across our state. But I think establishing more formal advisory groups from the outset would be good during times of public health crises.
Okay. So here in Ontario, we also found an insatiable appetite for exact numbers from our Ministry of Health. Many of those questions were not meaningful or actionable, but we had difficulty pushing back. Do you have any suggestions or reflections on how to protect your people and let them do their work?
Oh, yeah, that's a doozy. I think at the beginning in Victoria, we were almost too good at responding to those initial requests for data. So I was involved in the H1N1 flu pandemic in 2009, and we had a sort of a different leadership at the time, and we were very sort of clear that we wouldn't give to the granular information wouldn't be released. So we would keep to summary statistics. We wouldn't give the stories, of who infected whom and where did they travel to, and all that sort of those transmission networks wasn't really shared with our politicians or with the media. So it was kept fairly tight. Whereas with this pandemic, I felt like we did share a lot of those details about those transmission networks, which is important for one sense because you wanted to try to curtail the outbreak. But in another sense, it meant that every morning we were faced with the most sort of minute, detailed questions from any politician or media outlet or a group that wanted to know, about the smallest of details. So that's what burdened us as well. And it sounds like from your questionnaire that burdened teams around the world as well, and here in Ontario. I do think having a really good engagement with your communications and your media team and setting expectations from the outset would be valuable. And I think perhaps we didn't do that either. And because we answered the questions in the first few weeks, that we just had to keep answering the questions, and we couldn't put the hand up and say, no, sorry, we need to focus on this other work. And so, yeah, I think just intelligence teams can and should set the expectations and work with your chief health officer or your chief medical officer or advisor and your leads, and try to put a framework together about what is reasonable to share and what is unreasonable to share in terms of chasing those details down the line. That's probably not a great answer, but I think the more we communicate at the outset, like before a public health crisis, and set those expectations and those boundaries, I think it'll be easier for teams to maintain those boundaries during times of crisis.
Mm-hmm. Okay, we have 4 questions left, and I'm going to try to get through as many of these as I can. So considering lessons learned, would you recommend changing the lockdown strategy from a purely technical perspective? So removing political considerations, like would you have done things differently?
Oh, can you explain that question again? So
yeah. So
yeah.
like, given what you know now, like the lessons learned, would you recommend changing the lockdown strategy? Like, would you have done things differently, like, purely from a technical perspective and not taking into account the political considerations?
Yeah. Okay. So I mean, I do think that the duration of the restrictions and did probably, well, again, if we think back to the strategy, you're faced with a new infectious disease, there's a vaccine on the horizon, you've got the promise that the vaccine might be, you know, highly effective at reducing either severe disease or reducing some form of disease. And I think, again, given the environment in Australia being sort of an island nation, that pandemic restrictions were reasonable. But I think there were certain things throughout the course of the epidemic that we could have modified earlier. So, for example, we had empirical evidence that the severity of disease was relatively mild among children and young people. But we ended up locking down schools and doing home-based learning for a very protracted period of time, and that had impacts, mental and social and educational impacts on the community. So I think a lot of those decisions did almost become more and more political over time. But I think in hindsight, there may have been a less sort of punitive or a less restrictive mode of operating and mode of controlling the outbreak. And it probably could have been more nuanced so that it was didn't open up inequalities, so didn't disproportionately burden young people and children that needed to go to school, or didn't disproportionately burden our essential workforce. You know, the essential workforce, they were keeping Melbourne's economy alive. They were keeping us all alive. The cleaners, you know, food distribution. I think that in hindsight, being able to provide more wraparound support for that workforce that could have been put in place without, and at the same time being able to open up other areas that were less impacted by severe disease, like children and schools and education sectors. But I don't think we can ever divorce the disease control response and the political sort of response, because we're all humans and we operate in a society that has got complex, you know, economic, social, behavioural challenges. And I think this is one of the big challenges in public health as scientists. I know, like, as a scientist, I always sort of operate in a very sort of scientific, sort of binary black and white mode of, yep, well, this is what we need to control the outbreak. But you know, but human beings are a little bit more complex than that. So I think we can never really divorce the two. And I think just moving forward, then we do just have to, think about less punitive measures and support, sort of create that wraparound care for more vulnerable populations while being less restrictive, I guess, in the long run. But that's not a very good answer, I don't think, Jeff. But I think the crux of it is that it's really difficult to divorce the two.
Yeah. Okay, last question that I'm going to ask today, because we have 3 more questions, but I can only ask 1 more, I think. Given the stringent measures taken and the subsequent COVID fatigue, have there been any impacts to vaccine hesitancy and uptake?
Yes. So I actually haven't taken a look at Australia's data recently on vaccine uptake. I think the primary course was excellent. Primary course plus 1 booster was excellent coverage, but over time, and I think we've seen this globally as well, vaccine coverage has waned. I haven't looked at the impact of this over time on other vaccines and other antigens. I can hazard a guess that there may have been a shift. I think globally, some sort of childhood immunisation programs have been impacted due to the COVID pandemic, and I'm unsure what that looks like in Australia at the moment. But the hesitancy, I think, did wane over time.
Yeah. Okay, thank you so much for answering all those questions. Apologies to those 2 questions I wasn't able to get to. So as we wrap up today's PHO rounds, I want to thank Dr. Rowe for presenting, and I also want to thank everyone who joined us for today's webinar. You can expect to receive a brief and anonymous PHO round survey for today's session, so please try to complete this to help us improve our programming. A reminder to everyone that topic of the Ontario Public Health Convention will be held on March 26th and April 3rd this year. So please check out tophc.ca for details. Lastly, to access past PHO presentations and to view confirmed and upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. Thank you all, and have a wonderful day.